My name is Kelly Kulzer-Reyes, and I'm a graduate student in the Advanced Certificate in Disability Studies program at City University of New York. This final project is the culmination of my research and learning this semester. I'm also the mother of three. My middle child has a diagnosis of Down syndrome. She is 6, and her brothers are 9 and 2. Looking at non-invasive prenatal screening through a disability lens is complicated. If we look at disability without a feminist lens, it is slightly easier, but this oversimplifies the issue. There is a combination of outdated information about trisomy 21, or Down syndrome, and physicians' fears of litigation, which unnecessarily complicate non-invasive prenatal screening. If anyone thinks that amniocentesis can screen out the vicissitudes of chance, they do well to think again. No amount of fetal testing can guarantee parents the birth of perfect children. This quote comes from Michael Berube's 1998 book entitled Life as We Know It. With NIPS gaining momentum in the United States, parents will increasingly opt in to misunderstood but effectively marketed screenings, regardless of quantified risk. For those receiving negative results, this will serve as a false source of assurance that their pregnancy and expected baby are perfect. Those receiving a positive result, however, will begin a roller coaster ride. As we will hear from Skaperdas's ongoing and current research on NIPS, the complexities presented by positive are incredibly problematic. Since invasive testing like amniocentesis is still required for diagnosis, expectant parents are given confusing information such as a 99% chance of a 1 in 19 possibility of a chromosomal condition. What exactly is a patient supposed to do with such information? So what do we already know about Down syndrome, and what would help us share more up-to-date and accurate information with families about this condition? So one thing we need to do is build some common knowledge. In order to have a common frame of reference, I want to share a few pieces of simple background knowledge about what providers know about Down syndrome, as well as preferred language. Then we will move on to RAP's research on amniocentesis, Skaperdas's ethnographic study of women and cell-free DNA screening, and so on and so forth. So terminology. There are three main pieces of, or three main acronyms that we're really going to need to make sure we are all using the same way in order to understand screenings effectively, right? So NIPT is the term used most often in the marketing and literature. It's non-invasive prenatal testing, but what that implies is that the test is more diagnostic when it's actually a screening. So preferred terms in this paper or this presentation will be NIPS, non-invasive prenatal screening, and cfDNA screening, so cell-free DNA screening. So basics on preferred language. This comes from the Down syndrome community as well as from moms being in appointments with doctors who just don't get it. Person first language refers to people first instead of their condition first. So there's no adjective form of Down syndrome, so using it as an adjective is not accurate in a linguistic level, and it really just makes you sound like a jerk. So why does language matter? It sets the tone, language influences thinking, and it's something that we actually have control over in an early intervention area. So if you are using Down syndrome baby or Downs baby, God forbid Downs baby, you are setting the tone for parents, right? If parents' concerns are that they will have this difficult life and life is hard and all of these other parts, and you're impacting that language with not looking at this child as a person, you're part of the problem. Now, if they choose to use outdated language, that is completely up to them. You, however, are a professional and you don't need to do that. Consider using the word chance instead of the word risk or in concert with the word risk. So a lot of families have told me that they are very concerned, like they just kept hearing risk and this could happen and that. But let's think about that for a second. We never discuss a baby's chance of being a boy or a girl as a risk of being a boy or a girl, right? And yes, this is a chromosomal condition and we can accept that. but we don't have to set this stage to be overly negative. Risk is always a negative. Chance can be a negative or a positive. Consider that, please. In 2011, there was a discussion in the American Association of Genetic Counselors journal about prenatal screening and Down syndrome. And it actually made me think about how many people the average genetic counselor have in their own families who experience life with Down syndrome. Maybe a cousin, maybe a brother or sister, maybe even a neighbor. Just, did you have any experience with Down syndrome prior to getting into what you're doing today? And the genetic counselors in this discussion were in two different articles. One was, the original post was from, or the original critique was from Medeo et al. And Patricia Bauer, who's a journalist and a mother of a woman with Down syndrome, wrote a response to that group at the request of John Carey, who was, at that time at least, the editor-in-chief of the American Journal of Medical Genetics. So Ms. Bauer is a journalist who has served as a senior editor of the Los Angeles Times Sunday Magazine. She's been a special assistant to the publisher of the Washington Post. She's got lots of journalistic experience. But in her piece, what she wrote was really significant. I don't think most genetic counselors get this perspective very often. So Bauer said, "For us and for many other families, living in the company of a person with an extra chromosome is a complex blessing, not a curse." She also mentioned in her piece that non-directiveness does not mean honest responses are off limits. Non-directiveness does not mean you need to tell somebody that everything about life with Down syndrome is a comorbidity or another diagnosis, another difficulty. So what she thought would be appropriate for genetic counselors to do was to actually meet people living these lives, to make sure that they had a broad and rich experience. Prior to having my daughter, I had a limited experience, but some experience working with people with Down syndrome. But she is nothing like the people I worked with prior to having her. She wasn't like the guys in my group home. She wasn't like people I had worked with in schools. She wasn't like my mom's cousin's adoptive son. She wasn't like any of those people because she is herself. So basically, telling people that this is what will happen if you have a child with Down syndrome is just incredibly inaccurate. If you've met one person with Down syndrome, you know one person with Down syndrome, and that's similar in the autism community, similar in many communities. But in the Down syndrome community, it is such a wide range of presentation of the disabilities associated with Down syndrome. So keep that in mind, that non-directiveness does not mean you can't be honest. And honest responses are formed by having experiences, by meeting people, by enjoying, different experiences. Go to a walk. If you're in Southern California, come to Club 21. Volunteer, do something so that you have a broader skill set and more to share with your families. So where do our ideas and stereotypes about Down syndrome originate? I don't know where yours come from, but I can tell you about mine. When I was in AP Biology, probably in 1992, my high school biology teacher gave lectures on all kinds of different areas of biology. And the one that popped into my head as soon as my daughter was born was the one on Down syndrome. And that people with Down syndrome's chins were recessed so that they would be more baby-like and would be able to breastfeed longer, something like that. I don't know why that popped in my head or why 30 years later it's still in my head, but you never know where these things come from, or you just never know how something that's said to you is going to impact you many years later. So my life probably impacted it. My mom's cousin adopted a boy with Down syndrome when he was a baby, as far as I know. And I remember playing Frisbee with him as a child. I remember that same biology professor that I mentioned before talking about how in Special Olympics they use frisbees and throw them back and forth because people with special needs didn't care about, where they were running. They would actually get exercise this way. And I'm sure his I'm pretty sure his intention was, it was intended to be a positive thing, but those kind of paternalistic or not so positive views of Down syndrome stuck with me, and those are things that have kind of come up in my own life. Yeah, my daughter likes to play frisbee. Who doesn't? It's a little bit condescending to say that she likes it because she doesn't have the attention span to do other things. So my other areas of stereotypes have probably come from my family, from teachers, from the media. The thing that's really positive about our stereotypes today is that there's a show that A&E created a couple years back called Born This Way that actually challenges quite a few of those stereotypes. And having the media play an active role in demonstrating what life can look like for somebody with Down syndrome doesn't mean that all people with Down syndrome are going to have a certain life or a certain Hollywood quality about them. You don't have to be a superstar to enjoy your life. But those kinds of opportunities didn't exist so much when I was a kid. Media when I was a child included Life Goes On with Corky, and Corky was just part of our everyday family TV watching routine. So he wasn't foreign to me. He was just a guy who was on TV, who was part of a family, who was complex. He had feelings. He wasn't always happy. There were lots of things that helped defeat those stereotypes for me, but I think having more opportunities in the media now of demonstrating what life is like with different disabilities, not just Down syndrome, but it's more accurate and more inclusive, which I'm hopeful about. Now, some things that we can't control with our patients, with our friends, and with anything is that culture, education, age, religion, and every aspect of who we are impacts our ideas, our stereotypes, our acceptance, our non-acceptance of different aspects of life. That's something that is very complex, and I think is actually probably the hardest thing as an outsider that I see about genetic counseling. You have to know the complexities of different cultures. And if you don't explain something in a way that someone who only has a second grade education from a rural town in Oaxaca, if they can't understand what you're talking about, you're not going to be able to be very efficient or accurate with what you're doing. I don't think necessarily that the information about delivering a diagnosis is actually the hardest part. I think knowing who is in the chair next to you and where they come from and what builds on their stereotypes and their ideas is going to be even more complex.